Welcome everyone to today's webinar, Overcoming Blind Spots Using Analytics to Improve Performance. Health Systems CEO and Health IT leaders discuss how to close insight gaps that impact financial and clinical outcomes. I'm Mackenzie Garrity with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. We will also have a series of audience polling questions during today's webinar. When we reach each poll side, the poll question will pop up automatically on your screen. Our speakers will give a few seconds for you to select an answer from the options on your screen and click Submit. Thank you in advance for your participation. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by welcoming Dan D'Orazio. Dan is the CEO of Sage Partners, a healthcare research, strategy, and marketing firm devoted exclusively to healthcare. He has a long track record of driving successful outcomes for provider organizations, health IT companies, health plans, and investor groups. His skills span management, market and competitive intelligence, strategic positioning, marketing, and healthcare economics. I'd also like to welcome Dr. Gerald Groff. Dr. Groff is the Chief Innovation and Insurance Officer at Bassett Healthcare Network. He has been a practicing rheumatologist for over 30 years and has held joint administrative and clinical roles for more than 20 years. I'd also like to welcome Dr. Steve Liu. Dr. Liu is the founder of IngeniousMed and creator of the original application. He has served 10 years as the company's executive chairman and CEO and now functions as the company director and CMO with a focus on overall vision and direction of the company and its solutions. At this time, I am pleased to turn the floor over to Dan.
Good afternoon, everyone. It's a joy to be here. Looking forward to a rich discussion between Dr. Groff and Dr. Liu. And I just want to touch on a few key points to shape your lens as we walk through this discussion. There's 4 key points I want to touch on. The first one is about overcoming barriers to revenue collection. And before I dive directly into a few stats, I want to take a step back and look at the general health and challenges in our healthcare ecosystem. And if we look at how much our healthcare economy has grown just in this last 17 years since the turn of the century, so from 2000 to 2017, we were at 1.4 trillion in total healthcare spending in 2000. In 2017, we're at 3.5 trillion. So it's more than doubled, and that's a big number to double in a 17-year period. And so I bring this up because it starts to put increased pressure on all parts of healthcare, specifically health systems and providers. And if we take a step even further back, in 1970, we were spending about 6.9% of our total economy on healthcare. We're up to about 17.9% in 2017. So again, for perspective, it means for every dollar we spend on healthcare, we're not spending that on other parts of our economy. And inside of healthcare, it continues to put weight and pressure on every actor in that system. So when we talk about revenue collection at a time when we're having trouble sort of keeping the total spend in healthcare down, one of the natural reactions is to put pressure on the reimbursement side of the equation. And what's happened is in this, over time, the public payer has increased in their share of the market of the spend. So they're about 45% of total overall spend from a public payer perspective. It was about 32%, around the 90s. So again, the more public payer, we obviously know they reimburse less, the more pressure we're going to feel. And reports have shown that Medicare and Medicaid are not consistently keeping up with costs. One report has shown last year it's about $76.8 billion below costs. So what this means is everything we can do to become more efficient, to collect the revenue we're due, becomes really important. And that specifically touches on operating margins, and I'll talk about that briefly. The second point is that physicians are incredibly important in this equation as our partners. And we want to do everything we can to align our goals and incentives and get our physician partners the information they need. We've certainly felt the pressure of the EMR and taking our system hopefully forward. There's been a number of challenges there, but there's certainly EMR fatigue. The docs are the tip of the spear, and we need to give them all they need to really do the job that they came to do, which was help patients and do it in a productive manner. And so we're going to hear a lot about how to engage and align physicians. The third point is about value-based care. This is a term that's talked about a lot. Depends on who you speak to. Some think it's moving slower than others. Some think it's moving fast. But I want you to think about value-based care not only in terms of what Medicare is doing, but if you even read the headlines out the last couple of days, you've seen that Walmart has opened its very own standalone healthcare clinics, and they're offering a number of basic services. And what's happening is, if you've thought about value-based care only in the context of what Medicare has done, you're going to start missing the impact of CVS and Aetna and commercial payers and employers and the pressure for overall greater value that we all want in healthcare. And that will continue to impact how you operate, the kind of information you need to drive efficiency. And fourth, we're moving out of just a hospital-centric model, and that's been happening for some time. The number of revenue between outpatient and inpatient is almost at par, about 50%. But if you think about post-acute settings and outpatient settings, in post-acute you might have heard of this acronym PDPM, patient-driven payment model, and we're basically moving that outpatient world away from what's typically been a volume perspective to something that's much more clinically competent. And so in sum, we've got to have these pieces working together, but more importantly, we need to give people the right tools to operate to make that happen. So a couple of more points that I want to touch on here. If we think about the challenges that hospitals have faced, there's been a lot of discussion around operating margins. And in the period of 2015 to 2017, about 2/3 of hospitals, their operating margins were down 39%. And operating margins for me is, if I open the doors of my business, how much am I making or losing just by running my operations? It's really hard to run a healthcare business. We've seen some positive news in that the reaction of hospitals and the reaction of everyone in the system has gotten stronger in the face of these challenging times. And for the first time since 2015, we've had revenue growth slightly edge ahead of that expense inflation, but it's still challenging, right? Margins are still low, even if they're improving. So as we think about this environment, what I want to talk about next is, how do we give the right insights to run the best business that we can? And if we talk about physicians being so incredibly important to that process, what do we know? Well, we know that about a quarter of healthcare organizations have access to enough insights, right? So it's not that we haven't generated lots of data in healthcare, and I think as we continue to digitize and capture more structured data, we don't necessarily have the problem of having enough data. I think we're running into the problem of do we have the right data and the right insights? I think this is a great question to ask yourself as you listen to the conversation. Where would you fall out on this, on this chart? Do you have enough information? Or even if you have some, could you really use more? And is it getting to the right people at the right time to make important decisions, both about the clinical quality of care, but also the financial? Because you need to have great clinical quality, but you also need organizational and financial health to sustain yourself. And so as we move to the next slide, about 40% of the time, physicians' access to performance insights is missing. So again, the question is, can we be doing more? What other kind of data should we be bringing to folks, and at what kind of time and place and view? Everything from, is this real time? Is this before the visit, after the visit, not just at the hospital, but other locations? We've heard a lot about data. We need to move towards insights further. And with that, I want to get into, the discussion of our experts.
Hello, Dan.
Yes. So with that, I'd like to.
Gary Groff here.
Yeah, I'd like to introduce.
Go ahead.
Yeah, Dr. Groff and Dr. Liu, who have great, really great insights in this. And Dr. Groff, if you could just spend a little time talking about your background and your institution, it'll set the right framework. And then, Steve, you could do the same, and then we'll hop into the questions.
Sure, Dan. First off, thanks for that excellent introduction. Good afternoon, everyone. I personally am looking forward to this discussion because this is a challenging area for Bassett. Before I begin to review some of the background on Bassett Healthcare Network, I wanted to give Steve an opportunity to greet the webinar audience. Steve, good morning.
Good morning, Jerry. Thanks for having me here. I think we're both pretty excited to kind of discuss a very important topic. Probably the only thing I'll just mention from the background is just that, as a sort of healthcare IT company that's got a sort of a broad swath across our nation, we interact with and kind of converse with everyone sort of in the space of both healthcare IT providers as well as the actual health systems, and then as well as the actual provider groups themselves. And so there's some really interesting I guess trends and pain points also that are happening across the nation, which I think are very impactful with today's conversation. So looking forward to the conversation.
So Bassett Healthcare Network is a fully integrated system. We have employed physicians. We're located in a rural area of New York State. We have about 20,000 admissions and 800,000 outpatient visits, so we're heavily weighted to the ambulatory component. And we've been an Epic shop for about 8 years. We started with outpatient clinical, moved to hospital, typical for many systems, and then added revenue cycle in 2018. And I would say that we're near enterprise. Now, from the beginning, we've had a business analytics group from the first 6 or 12 months of Epic. And we can talk about this, but back then we decided to build our own data warehouse based on the SQL Server and Epic Clarity. And since then, we've been able to link Epic real-time data with external claims files, and that's been really valuable. I think in many respects, because we're an integrated system, because we're able to get at claims files, we've solved the data aggregation problem. On this, we've overlaid software. So we literally have thousands of reports, searchable dashboards. I would say an insatiable demand for reports, although people don't always use them. And despite those advantages, having the data, having the reports, we find ourselves often with really limited actionable information in our dealings with the insurers. We are searching for better performance insight, and I'll give you one really simple example of this. An insurer came to us with the concern or the complaint that our patients were using the ED too frequently. This was based on their claims files. Well, it resulted in a deep dive, a lot of manual work, chart review, and we discovered that although the discharge diagnosis was a musculoskeletal complaint or simple GI conditions, the admitting reason for going to the ED was chest pain. And, of course, chest pain is almost impossible to redirect from the ED, and you shouldn't, so that the insurer's conclusion on this was incorrect, but our need to spend too much time and too much effort to discover the obvious is still there. This process, in our view, should be automated. It should be quick, should be direct, and for us, it is not. So I know we'll talk about other examples when it comes to revenue cycle and the physicians, but I would stop there. Steve, any added comment?
Yeah, so, kind of talking about insights in general, I mean, one, it would be so nice if it wasn't, these intricacies and quote, minor details don't have, tremendous impact, honestly. And it really is sometimes simple stuff, but diving and finding, the issue is where all the resource and headache is kind of spent. In terms of insights, I just to add to the confusion of this, I think my point is that it's not necessarily the what, but the level of insights, I guess. Jerry and I are both physicians, and I think there's a little bit of bias, but I mean, physicians are one of the most powerful, kind of entities in healthcare, and that they're the folks who are actually executing on the ground. And so, their success or failures become the health system or the practice's failures and success. I used to say that, my pen, or in this case, my keyboard strokes on the EHR are one of the most powerful things because it impacts quality or cost or financial impacts. And so whatever you can do to give those physicians the tools and the insights so they can be better is actually probably one of the biggest ROIs. And so when I say the level of insights, I think folks typically kind of focus on sort of the system-wide, analytics and insights. But there's actually another level that's maybe even more important, so that at the actual physician practice level and even down to individual physician performance and true attribution that's trustworthy. And so I think for organizations who are kind of managing and wrangling all this data and trying to get insights, not to lose sight of kind of doing all layers of the pie, I guess, to get the folks who on the ground the tools to be successful. And maybe the last point I'll make in terms of gaps would be, health systems are bigger than sort of, the technology that's there. They're partnered up. They've moved into different spaces outside the hospital. And so even though you have a massive data set, there are holes in that data set too, in terms of like post-acute, as well as people partner up with their private practice affiliated physicians to manage the care of a patient population. That's also, unfortunately, a data siloed area as well. Yeah, Jerry, any thoughts?
We certainly agree with you in terms of the importance of physicians. We are a physician-led organization. Our CEO is a physician. And all of our providers are employed. Unfortunately, employment does not necessarily mean full alignment. And so the more information you can give them, the better. It has to be objective. It has to be trustworthy. We can talk about that, but I agree completely.
Yeah,
it feels almost like we're back in the 80s where there was a heavy employment, and then honestly that didn't work as well as everyone thought, because employed doesn't necessarily mean aligned, and maybe it was a management thing back then. I think we're hopefully smarter these days.
Yeah, an interesting fact there around that, it's been pretty well established that through data that when physicians are employed, there's been about a $250,000 loss per doc, but that's improving. Recent data suggests that loss has come down to $201,000, so about a 21% improvement. So I think the response that's happening in the market is positive. And I want to come back to this issue where we started with revenue. And what are those challenges in terms of optimizing revenue? Because in my perspective, in the run-up to getting everyone on an EMR, there was a tremendous focus on the clinical side of the equation. And in many ways, revenue cycle was important, but it might have been a little bit on the back burner. In terms of how healthcare continues to progress with both value-based care and all the pressures that I described earlier, can you guys talk about the barriers to optimizing revenue? And we have a poll up on the screen. It'd be really great to get feedback here from the audience around this particular question as the discussion unfolds.
So, good question, Dan. This is Jerry. I think I mentioned that we went with the revenue cycle, Epic revenue cycle, in the spring of last year, 2018. And like many organizations, we saw 3 to 6 months of delayed reimbursement. And as part of the correction process, which was difficult and detailed, we exposed areas for us that were real challenges, and they're ongoing problems. And my guess is that we had those problems before the software transition, but our discovery process really underscored these, and I would list at least 3. The first is that we have difficulty with accurate documentation of clinical complexity. Our providers tend to put 1 or 2 diagnoses up there. They don't think about all the work that they're doing for a patient, whether it's inpatient or outpatient. And we lose complexity scoring as it applies to our insurance contracts, Medicare Advantage, and other important value-based programs. So that's number 1, and something that we've struggled with despite our attempts to educate. The other area that was obvious, and again ongoing, is that our providers and the staff really have a revenue cycle challenge, keeping up with the rule changes. This is a constantly changing target. And we find that we can educate the physicians in a particular area of revenue cycle, but they either forget or the rules change. And in many respects, we have to do a better job in automating the background of revenue cycles so they don't have to worry about it so much. The third area for us is accurate pre-authorization, different kind of process, but again, that was brought to light as part of our discovery. So those are the 3 main areas that we're working with. We have work teams. They're on it constantly. They're providing feedback, but the progress is too slow, I would say. Steve, your thoughts?
Yeah, I mean, it's interesting that, sort of, I guess, the magnifying glass exposed kind of areas of, problems, but also, I guess, opportunity, huh? I think one of the challenges is when you have sort of any sort of revenue loss or trickiness with kind of capturing sort of, that part of the financial picture, it's not even just the revenue that's lost or delayed, but it's almost like a double whammy because of what you're kind of alluding to. It's also the data that comes with it in order to run the business, right? It's data to manage the physicians, their productivity, their performance, comp plans, staffing, heck, even contract negotiations as you take on new parts of business. And so I think the key is for folks in the nation as they kind of go through their own journeys is just to do what you can to have backstops. I don't know if it's even possible to prevent anything that might happen. Maybe hindsight's 20/20. I'd be curious to see if there's anything you would have done differently. But backstops in order to just make sure you are capturing everything, because it's such a critical part of the organization that can't fall down in any sort of HR rollout or transition, and that's typically where we get called in. Actually, Jerry, would you have been able to catch anything or?
Well, often these problems are obvious and simple, and yet somehow they work their way through the system. I give you another example. 3 or 4 months after our revenue cycle transition, our surgeons were doing ambulatory surgery, as they usually do, and occasionally will send someone to observation for extended recovery. All fine, normal clinical process. Unfortunately, the way things were constructed, these cases were billed out as observation rather than ambulatory surgery. The reimbursement is less than 10% of ambulatory surgery. This was in the millions. Something that we should have recognized early, or should have been brought to light, or prevented with, as you call it, a backstop. That should be in the system at all layers, right? I mean, this is obvious, and folks on the line will probably say, well, how could you possibly let that happen? Well, you don't. You just don't know at the time, and it takes a while to discover. Anything that we could do to automate the process behind the scenes, I think, is going to be essential. And I think that's what you're talking about in terms of systems work stops.
Absolutely.
Yeah. Steve, to the couple of points that were just discussed, can you talk about, obviously you started this company, you saw a problem, you were working on a Palm Pilot years ago, you knew that there needed to be more done. And so this issue of automation, I'll call it the EHR hangover, maybe some of the unproductive effects of how healthcare has evolved. Can you talk about how you guys saw these problems around automation? And first, the second one is you talked about that it's not just revenue, but all the other things that physicians need to do in terms of, capturing data to prove that things are, if there's an audit, things are done properly. Just the automation and the capture and all the other things that you've built, the problems that you've seen as a physician and how you've translated that into technology to make physicians' lives better and more productive.
Yeah. I'm a practicing physician still, not as full time, but thankfully, because it's busier than it used to be. Life is harder. There's more things to do. Different workflows with technology, and so anything we can do to make me or my colleagues better is really important. So automating kind of manual human-based workflows is a big thing of what our company does, automating that stuff and then enhancing revenue, and then if you take on value-based stuff. But also the other important point is to take the data from that to then leverage it and give tools, kind of to the prior discussion, information to those physicians so that they can actually kind of, be great physicians, put it that way. And so I think one of the, biggest, returns that an organization can do is to help those physicians at the actual point of care, point of decision-making, point of documentation, whatever it might be, and give them insights, arm them. It's very powerful. But it has to be done right. So, like way back when, I started the company way back on like old Palm Pilots. Those are the ones where, if you took the battery out, you lost all your data, right? But that was used really originally to capture claims information. But really what it was built for was to capture data and to automate that data collection process wherever we were. And back then we were actually a little ahead of the game in terms of where everyone is in terms of we were doing post-acute. We were doing acute care locations. And so I needed that data. And it was interesting because when you take that data and you marry it up and you give it back to the physicians, because it's truly, it's attribution for what their productivity, their actions are, you can engender true change, behavioral change. And so I think the keys for folks as they kind of do their own, methods of engaging physicians, it has to be timely for sure, but it also has to be trustworthy. And the wonderful thing about claims information is it's their data. You can't dispute it. And so as a result, trustworthy, Dan, to your question, trustworthy so that I could show my hospital systems what we were doing. I mean, unfortunately, I hate to say it, but there's sort of a bias that hospital data is wrong about physicians or physician practices. And back then I saw it. They said my group was the worst group with the worst length of stay and productivity and satisfaction. And turns out, because I had our system, we actually had the best efficiencies and length of stay and readmission rates and all this stuff. It was just wrong data. So that's important. I would also counsel folks as they kind of build out things that it needs to be trustworthy in terms of the data for the physician. All it takes is one single nitpick on something that's wrong, and they can discount the whole entire data set of what their performance is. So that takes time and effort and resources to make it good. But if you can do that, and then you can show physicians and actually every physician in the group. Don't even, de-identify it. Show them their data compared to their colleagues. I didn't have to do much to manage a whole group of physicians. All of a sudden, the hardest working physician realizes he's really not working as hard as everybody else, or the poor guy who's killing it and just beating himself up. He's not doing great care, and he's spending long hours. He's actually doing above and beyond everybody else in the group. So you can reward sort of your best physicians. So anything you can do to take that data, get it to the physician so they can look at it in real time, that changes behavior. It helps you to be successful.
Yeah, that's helpful.
Yeah, Dr. Groff, it certainly sounds familiar to our system. We have 550 providers and about 350 physicians, and we've been working on physician and provider performance reports for over 20 years, and I have to say, it's still a work in progress. It's RVU-based. We use external benchmarks. It's transparent within a specialty group. We've layered on quality metrics and other performance metrics, but it requires a constant system of review and improvement because, as you mentioned, Steve, it has to be accurate or you lose all credibility. Physicians have to trust the information, and it has to be meaningful in their lives. It can't be an obscure measure that really doesn't connect with them. We find that since you can't always be 100% accurate, that when you do find errors, you need to have feedback loops for any flaws. You need to correct it. You need to be transparent about it, and that over time builds up trust. The other thing that we find is we focus on one priority issue at a time rather than a dozen or 10. We'll take one that's important for the group and refine it until folks are comfortable. It takes time, but it gives really the best results. And I think we've gained trust. As you mentioned, Steve, the best collegial influence is comparison to colleagues with trusted information. We're still working on it, and I would say that anything we can do to increase the immediacy and the accuracy of the information is better. RVUs are delayed. If there are data sets that we can track in a more immediate way, I think that would be most welcome to our particular program. And a lot of things, Steve, you were talking about is in that area. So It's interesting stuff.
I wish it didn't take so long to get to great reports, huh? It is just it's a lot of work. Back to you, Dan, sorry.
Yeah. I was going to say the next, and you started to talk about this, and Dr. Groff, you talked about employment doesn't mean alignment. Alignment's incredibly important as we move into the new world and the new challenges of healthcare. We're going to send out the results of the survey, but I just wanted to share a few. The top two challenges that people noted were, I think, in line with the discussion. The first one was around physician alignment, and the second one was insufficient data. So Dr. Groff and Dr. Liu, exactly what you've been talking about, the audience is echoing that. So how have you aligned those physicians? You've talked about getting the data to be trusted, but have we made enough progress? You said it's a work in progress. Have we turned the corner at all on this issue? Maybe compared to 5 years ago? Dr. Liu, as you said, this is harder than it used to be. So I'm wondering, how do we measure if we're really driving alignment and knowing if we're making progress here?
I mean, I hate to say it, but just even so the good news is that people are focused on it. The fact that those two things rose to the top is probably, problem solved number one. Just the fact that is, the priority. I think it is also very hard, especially as you are dealing with reams of data, as we kind of mentioned before, and then trying to get those insights that physicians will actually trust, that are meaningful and so forth. And I think that's probably the challenge. We've probably gotten better in my opinion, I think there's a lot that can be done, which is great. I mean, it's kind of like when you see a patient. Sometimes the challenging ones are when I have no thing to treat you with because I have no idea what's going on. Well, we know what the problem is here, and so if we can just do that, get data, get it to the physicians, the medical directors, the folks who need that in order to run their business, then a big problem solved. And it's like Jerry mentioned, it's almost a lifelong thing. You're never done with it. It's always going to be something you have to kind of spend time working on.
And Dan, this is Jerry. I think from the perspective of trusting RVU reports, our providers have begun to pay attention to the rules of revenue cycle in the way that they never did previously. They would basically, if not ignore it, then just not take this as part of their daily work. And I think there has been a shift in that general area. There's a tremendous amount of work that still needs to be done when you're looking at clinical quality measures and service performance. These are very difficult to isolate out and track. We've only just begun, and I know that there are success stories out in the industry, but it's difficult work. And if you were to ask our physicians which types of measures they would value more greatly, it would certainly be in the clinical performance and service area. So much to be done there.
I might even add to that, Jerry. It's interesting. I think back to your question, Dan, in terms of what else needs to be done. We come across organizations where the frontline physicians literally have no idea what the healthcare system strategically is trying to do, and they're just not aligned. That's one of the things we do is we actually kind of make sure that either the practice or the organization's kind of metrics that we actually impact literally meet the physician's eyeballs on a daily basis when they get into our platform. That's how you get them to focus on things. And I would also say tying organizational strategies to physician incentives. If you tie it to their wallet share, you get change in behavior. It shouldn't be that way, but it is. And anything you can do to kind of just ensure that they're also winners if they do well is very helpful too.
Yeah, Steve, I'm interested in, you guys you're in a lot of health systems across the country, and you've been at this for a while. Really interested in what you guys are actually doing, like you said, putting this in front of them on a daily basis. But can you point to some examples of how you've been able to, with your insights, help to drive that alignment and take this out of, a theoretical discussion and down to the actual daily practice level of the kind of things you're giving the physicians and the organizations that change how they not only understand the problem, but what they could do differently?
Yeah. So granularly, we have all this great data, and we leverage it for dashboards and reports. And we, talking about automation, you can't. It's one thing to actually have the report, but that doesn't necessarily mean that it's used. And so it's actually extremely important to not just have it, but then get it to the actual clinicians who need to see it, put it that way. So it's that last mile finishing the race. If you don't do that, nothing happens, right? And so our clinicians, every 2 weeks they get a scorecard of how they're doing, how they compare to the physicians. Hey, I've got a great length of stay, but my readmission rates are high. And I'm the worst in the group. I'm going to change that. So pushing it, not letting them pull it because they just won't. They won't do those extra clicks. You've got to push that information to their eyeballs so either subliminally or actively they see how they compare so that they can change and not be the worst guy in the group or whatever, or reward the best guys.
Great, thank you. Just a reminder, great discussion. Please submit questions. We'll be taking them shortly. I want to move to this discussion around how you deliver and coordinate care beyond the hospital walls. I mentioned earlier on that we've known for some time that we can't just be in a hospital-centric model, but the continuum of care is really difficult to coordinate for lots of reasons. And I'm curious how you guys have approached that in your organizations and how you've gotten better, because I know we have to get better, and there's also, the stick of CMS playing a role here, but just from the need to get better and from an efficiency and a bottom line perspective, we've made improvements. So this issue of care coordination outside the hospital is an important one, and I'm curious how you've been addressing it.
So Dan, Jerry again, we have the Central Specialty Hospital in Cooperstown, the Bassett Medical Center, and 5 affiliate hospitals, all on Epic. So we have access to data from all of those sources, as well as our greater than 50 ambulatory clinics. Our challenge is that we also have home care, visiting nurses, nursing homes, DME, community navigation on different platforms. So we struggle with pulling in their data sets. Now, we do have the availability of Epic Care Link, which is a passive lookup by community members into the electronic health record, but you can't share information and you can't share notes. New York State has a data sharing initiative called HCSNI, and there is some central sharing of information regarding admissions and ED use, but it's very limited. You're aware that Epic has record sharing through Epic Care Everywhere. And then, of course, we're able to transfer claims files at the Bassett system from Medicare through a part of our ACO, Medicaid, and our commercial insurers. Even though we have all of that data, it's really barely touched the surface when you're talking about community care and the relationship to clinical and performance tracking. We have a lot of information internally. We have partial information externally, and it's a struggle for all of us, I think. Excellent internal data aggregation, but we're still working on bits and pieces from the outside. We're looking for solutions, so Steve, what are your thoughts?
It's the holy grail, right, to kind of get it all. Healthcare systems have grown, and they've grown outside of what you can physically get to with your main EHR, and I think that the areas of I guess black holes are in that post-acute realm, where you don't have those facilities, or you have joint ventures and whatnot in nursing homes and SNFs and rehabs. And it's not just the data, as you're alluding to, Jerry, but it's also the ability to influence care in those locations where, you may not have providers, or you have affiliate physicians who are caring for your patients, that patient population. And so, kind of that whole partnering up in order to get those data points, but also getting a footprint so you can influence the quality and the efficiency of care in these places. And it's interesting. It's not just to the physician providers, but also kind of what you're saying is it's also all those affiliated services like home care and whatnot who are also part of the continuum of care, and they all can make a big negative or positive impact on sort of the care of that patient. And so I think, there's actually a really nice kind of, area here for third-party vendors like ourselves where you can come in and extend, the EHR. And that's kind of what we do is we kind of help the EHR to kind of go to the places that it doesn't go and get the data and to bring it back and be a platform for insights or things that will change behavior that come from, the EHR, from administration. And so if you can kind of marry up, that, then you've got something that kind of spans the whole entire, I guess, spectrum and continuum of what a healthcare, integrated delivery network is trying to do. It's a challenge, but there's a lot of opportunity there.
Yeah, we have been a lead agency for a Medicaid DSRIP in New York State. We had all the incentives and support in the world to be coordinated and organized with our community partners, have over 100. It really was and has been a tremendous challenge. We've made progress, but the things that you're talking about in terms of data collection would help us.
Yeah, and Jerry, your organization is way ahead of many, or I think many can only imagine kind of having the level of integration and sort of progress you've had. And yeah, to hear that even still there are challenges is fascinating and also disheartening, and also there's opportunity, I guess, here too.
Well, we aren't disheartened yet, but we're trying to avoid that.
Yep.
Yeah, it leads to a great question, the last question, and then we'll open it up to some of the audience questions. We've been talking about the proverbial foot in two canoes for a long time. But I pointed out earlier that this might not just be about Medicare. This might be about other market forces. And we're seeing employers in the market respond, and I think the term value-based care might become even more than we thought of it previously. How are you dealing with this shift in terms of getting there, and why you have to still live in fee-for-service?
So at Bassett, we're still mostly fee-for-service. I would say our value-based contracting is about 30% of our revenue. We have a Medicare ACO. We have a commercial risk arrangement with a regional Blue Cross Blue Shield. We're self-insured for our employees, so obviously that's 100% risk. And as I mentioned earlier, we're a lead agency for a Medicaid DSRIP. And we believe in New York State there will be a strong trend to manage Medicaid, so you'll have to be ready. The things that we've been talking about in terms of data collection and performance and the ability to prove performance, I think supports both worlds, really. I mean, it's as much an important part of our mission on the fee-for-service side as it is to prove ourselves in the value-based side. So many of the projects and initiatives that we've started regarding clinical performance literally supports both areas. They're not mutually exclusive. I think it's just looking at this as clinical and business performance improvement, and you can advance in both areas, I think, simultaneously. That's my view on it. Steve, what do you think?
Yeah. No, they're tied to the hip, aren't they? We have actually in our client base some of the nation's largest, I guess, most respected kind of value-based health systems like Kaiser and Geisinger. Folks aspire to that, and they still have a component of claims, either for revenue or for the work that's captured, even though you're not submitting it. So I think fee-for-service, fee-for-value, they're interrelated, I guess. You can't take on value unless you've kind of maximized your rev cycle and have your house in order. And then more importantly, you need that data for the work that's performed by the physician services in order to take on and be successful with value-based contracting. It's funny, but I guess with bundle care initiatives and some recent timelines over the past few months, I've talked to CEOs who have jumped on with no idea if they're going to be successful or not, and they have no idea the costs that they're currently incurring in order to provide these services. And again, it reminds me back of the 80s where practices kind of took on some risk without being able to measure, if they're being profitable with it. And so revenue capture versus work capture, they're flip sides of the coin, but both very tied to sort of financial outcomes, and and maybe even the diagnoses that are related to those claims are even more kind of gold, I guess, of importance. So I'll throw it back to you.
We learned a great deal with our self-insured population. Obviously, again, 100% risk. Many of our analytic models were tested in that group, first, and then we've gradually expanded to other populations. We're at the point of representing programs originating from our self-insured population to the commercial insurers because they work with risk, but they also work with the commercial fee-for-service population.
Mm-hmm. Yep.
Yeah, so guys, I want to take a few questions. We've got some really good ones coming in. The first one I'll ask is, what is the best way to engage physicians and help them brainstorm the actual data reports that would improve their performance, right? So instead of sitting up on high and saying to people, hey, here's what you need, or here's the reports that matter, I think this audience member is saying, how has that actually worked in practicality to get their buy-in? We've talked about alignment. What's worked to get them to be part of the process?
Let me think about that. Well, all right. So you start with a top-down approach. You know, at the medical director, you know, a regional director kind of realm, because they're tasked to do certain things for the organization. And you would, you know, present those information and data and all that. Is it a dialogue? Absolutely. You know, so there are certain things where you just never foresee. Hey, you know, you're measuring us on this, and we have no ability to impact that. And so you pivot and you change it to something. So I do think it's an absolute dialogue. There are some things that are pretty proven and time tested to manage physicians on, where there's not that many iterations of it, but there will be things that you have to almost throw against the wall, and if it doesn't work or it doesn't incent, you know, be open to, you know, the client or to the physician in this case on what's a better way to help. And, you know, and if they're incented properly, they will work with you on to create a metric that they feel they can execute on and change, and you know, that you're happy with too. So, you know, without getting specifics, yes, it does need to be a dialogue.
Dan, I'd say in the first year of our performance reports, physicians either ignored the reports or burned them.
That's funny, but not.
They weren't relevant. And after a year, we went to them and said, okay, you know, we tried to make these as accurate as possible. How could we make this meaningful to you? And from then on, we've been working carefully on real incentives, whether those are compensation incentives or time incentives or other kinds of things that providers find important and valuable. There has to be some kind of link to something that improves their world. Without it, you'll never get their attention. They're too busy. There's too much work to be done. And the dialogue part of this is very, very important.
Yeah, that's really helpful. I want to take another question about a topic that's important. Someone's asked about how you get physician office reports around social determinants of health into a hospital record. And I know I might be asking a really difficult question. I'm not sure anyone has solved this. But can you talk about the integration from the physician into the hospital setting, especially if the physician's office knows something about, you know, someone that's really important that might impact a discharge or the kind of treatment you might actually deliver? I mean, social determinants is such a hot topic. Has that come on your radar from an operations or practical level?
This is Jerry. At Bassett, the social determinants can be registered in areas in EPIC, but I would say that our primary care group is good at this, but not systematic. And so there are gaps in understanding what's happening to our patients. We've created a parallel system of community navigators in all of our counties, originally supporting Medicaid, but now expanded to the Medicare and commercial payers. And they have a very real day-to-day focus, not only on social determinants, but on the necessary intervention necessary to support our patients. And we do connect the two platforms in terms of information sharing between EPIC and our community navigators, and that has really been a tremendous resource in the organization. We've shifted in 2 or 3 years to a much greater knowledge about and influence on the importance of social determinants. Steve?
Really nothing to add other than, I think it's just a great example of where sometimes you have to use, maybe a parallel but complementary system that's actually in use in order to get important data to the people in use. Like, so for example, we showcase, bundle care patients or ACO patients or ones that are value-based and certain details that, at least at this day and age, EHRs may not ingest, but they're critical for decision making. And so, just whatever way you can get it to the people who are executing on the care in the hospital in this case, is how you can get it, at least right now.
Yeah, great. I want one final question. This is a really good one. It's from someone who's a post-acute provider with a SNF and home health. And a provider business, and they're constantly trying to improve care coordination. And the question's really about how do you get frontline staff to understand the why? There's a great book out about Start With Why. How do we make the connections for everyone? So I think this goes back to we have a lot of data. Do we have the right insights? But this question says to me, how do we really get accurate data and create the buy-in? So we talked about that with physicians, but what about the other people in the organization? Because this doesn't just start and stop with the physicians, right? Sort of to turn this tide. I think that's the essence of this question.
Jerry, I'd be interested in what you think of this one.
I think you need to share the information on a regular basis. We learned this through our Medicaid district, where we were very much dependent on non-systems nursing homes and at-home care, visiting nurses, community members. And the breakthrough did not occur until we started to meet on weekly and a monthly basis as work groups in different geographic areas and shared the results of our studies and of our deep dives and our analytics in the room at the same time with different layers of care delivery. I don't think you can do it distantly. I think you need to be in the same room talking about real patients and sharing the deeper information with those folks who are at different levels of care. Until we did that, we struggled. I think one of the success stories of our district was that we started to come together on a routine basis.
Jerry, I wonder how much of it also is just, you kind of mentioned, kind of just this project and that project. I mean, 30% of your payer mix being kind of value is actually, pretty impressive. It's almost like you have to reach, kind of climb that mountain until there's a point where there's enough momentum where you can have these kind of conversations and the culture changes a little bit too in order to have this.
It's certainly gradual, and again, it's built on trust and many of the other factors we've been talking about. It takes time.
Dr. Groff, Dr. Liu, and Dan, do you guys have any final thoughts?
Only that I think it's been a very valuable conversation for me. This is Jerry. We have many advantages, but we have a long way to go. And I would be very interested in ideas and concepts that would come from the audience that we could share collectively. Thank you.
This is Steve. I have been looking forward to this conversation with Jerry, but also, I guess, in a way, with the nation on just these very important topics. I think it's a very timely place that everyone's trying to figure out answers to, and we probably have some answers and ideas on this phone call, but I'm sure there are others out there, and just looking forward to kind of where the nation goes here.
Yeah, and I would just say, I can tell you by the questions coming in, this is certainly going to take collaboration and sharing of ideas. I don't think there's any one right answer. So thank you for everyone for sticking with us. Great questions here, and Dr. Groff and Dr. Liu, appreciate your sharing and your experience.
Welcome. Take care.
Thanks, everyone.
That is all the time we have today. I want to thank Dr. Groff, Dr. Liu, and Dan D'Orazio for their excellent presentation and IngeniousMed for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.